So Dr. Madan Gopalan, ma'am has shown easiest path, no, for these cases. Why do you want to walk the difficult path? Can you unmute yourself?
Yeah,
Yes.
I will just share my slide now. Okay,
Yeah.
and hope my slides are visible. Yeah. So, a very good afternoon, everyone. I thank the ARC and its chairman for this wonderful opportunity. After that, a wonderful talk by ma'am herself, enumerating the benefits of iris claw lenses, I understand that my task is a little tough. Anyway, I'll speak in favor of SFIOLs. So the first question that comes to mind, and ma'am has been repeatedly showing a lot of videos, an iris claw lens is okay for this eye. But what do we do here? An iris itself is not present. These eyes have no capsular support, yes, but cases of complicated cataract surgery or ocular trauma often present themselves where the iris itself is damaged. Many a time I've referred these cases with retained nucleus or retained IOL where the iris has been damaged during primary surgery. Placing an iris claw lens here is very difficult, if not impossible. Even if the condition is very favorable, even if we have the best surgeon operating, the eye on the left is what you would end up with. Worst case scenarios can look like the eye on the right. What I'm trying to say is that iris claw surgery, although shorter in duration, although simple, it offers very, very little margin for error. As long as enclavation is not done, things are okay. But once you enclave, you better get it right at the first instance. If you have to disenclave and do it again, things become really messy. This is a picture. I just took it 2 days ago after I was given this topic. I took it 2 days ago in my OPD. A very well placed iris claw lens, I must say. But as a VR surgeon who did the retinal detachment surgery about 2 days ago, I can tell you two stories looking at this picture. One, the patient has had a retinal detachment after primary iris claw placement. Why? I leave it to you to guess. Two, this is the maximum that this pupil will dilate. This is the maximum that this pupil will dilate. So dealing with a macular pathology or a pathology in the mid-periphery is relatively easy, yes, but dealing with a peripheral problem is really difficult, especially after doing a retinal detachment surgery. If I want to check the periphery, if I want to make sure everything is fine, if I want to make sure my break is flat, it is a little difficult. So that's why an SFIOL is preferable. There are various methods and techniques. This is an article that goes into SFIOLs in detail, but for this very short talk, let me just mention that broadly an SFIOL can be looked at as a sutured or a non-sutured one. The 2 points fixation using a 9-O-proline is the simplest, all of us know. But you see, this kind of creates a pivot on whose axis the IOL can rotate. As ma'am was mentioning, IOL rotation and tilt is possible. That's because you're having only 2 points of fixation. To eliminate this, we moved on to another technique of 4-point fixation. It's a little more complicated, but again, the stability is a little better. You can use scleral flaps or you can use Hoffman pockets. Now that was about suture SFIOLs, and I'm sure all of you will agree that we are now doing more of sutureless SFIOLs. This requires the use of three-piece IOLs that have larger overall diameter and Prolene haptics that are more forgiving of haptic manipulation. Gabor started it off with this tunnel and tuck method. Agarwal has popularized the flap and glue technique. But anyway, whatever choice is yours, it's fine. Another recent modification about the Yamane technique, he uses a cautery to create flanges. But my personal favorite remains the simple XNet technique developed by Dr. Prabhu of Aravind Eye Hospital. It's a completely extraocular procedure. The argument, as ma'am said, the argument against an SFIOL has always been that it is difficult to perform, it requires a lot of instruments. Well, this technique simplifies the entire process. The exteriorization of haptics is performed using a 26 gauge needle or the XNet kit. And the entire process of haptic docking happens outside the eye. As you can see here, it happens outside the eye. So complex intraocular maneuvers that are prone to, create problems, they are eliminated. They're completely eliminated. It's a completely extraocular procedure. So the first haptic is exteriorized. The second one is also exteriorized in a similar manner. Readily available instruments. Just have to dock it and pull it out through the other side at 3 o'clock. Once both haptics are exteriorized, you see that here I'm using no flaps, I'm using no glue. The haptic can be tucked into the preformed scleral tunnel by using the intraocular forceps or the McPherson forceps that is readily available. Now you see in this particular eye, the iris is damaged. The pupil is not very regular, but still an SFIOL can be placed with very good results. Now we have innovations like the CM T-Flex SFIOL by Dr. Nivian of Chennai that is really creating waves. This lens has simplified things even further as far as fixation of an intraocular lens to the sclera is concerned. It's foldable. It's got a T-shaped haptic. All it needs is a simple grasp, pull, and release technique. We avoid the complex haptic manipulation and those maneuvers took time, and those maneuvers are often cited when speaking against SFIOs. So these kind of SFIOs, they eliminate the problem altogether. We see that it's acrylic material, pliable. So a 23 gauge sclerostomy is all that's required to gently pull the haptic out, the T-shaped haptic out, and leave it. So since it's made of acrylic, it simply springs open and anchors itself to the sclera. The same is repeated for the other side. We use a handshake maneuver. The second haptic is pulled out by holding the center of the haptic in a firm manner. Gently pull out the haptic from the other side at 9 o'clock meridian. Once it's out of the eye, we release it and we see that the T-shape springs back to its natural position and anchors itself to the sclera. And that's about it. It's as simple as an iris claw lens that man has been showing. So in summary, what's often quoted against an SFOL is the duration of surgery and instrumentation required. But as I explained, with present techniques, these no longer hold ground. On the other hand, there are many advantages. Most important among them is that a vital tissue like the iris is not disturbed unnecessarily. Dilation is good, inflammation is not prominent. IOL occupies the same position as would an in the back lens. Removing or repositioning an SFOL for whatever reason, be it during primary surgery or later on, is relatively much easier. As I said, iris claw lens offers very, very little margin for error. Whereas an iris claw lens would require less training, less surgical time, and the patient finds immediate post-op period more comfortable, the advantages of placing an SFOL begin to show up after the initial few weeks. Of course, it's important to start well. It's more important to finish well. As a VR surgeon who uses all types of these lenses, I have no hesitation in saying that SFOLs are better in the long run. Thank you for the opportunity and your time.
Thank you very much, Dr. Madan Gopalan.
Yeah. Very well. Actually, yes. Harshul, we are really running short of.
Yes, ma'am.
Sorry, I'm going to ask Madan Gopal just one question, and I'll go on to the next speaker. If there is a scarred conjunctiva from previous surgery, Dr. Madan Gopal, how would you plan your haptic positioning?
Depends on where the scar is, ma'am. Usually, the scar would be superiorly. Hello?
Yeah.
I'm audible?
If it is
the scar that you talk about is going to be superior, ma'am, because somebody is going to have you open the superior conjunctiva. I have no hesitation in using that place for a tunnel again and putting the haptics temporal and nasal.
Okay, right. Thank you.